from a physical therapy, athletic training, rehabilitation standpoint, what can we do while we're working with these patients to help to decrease things like fear and improve confidence throughout the rehabilitation setting with hopes of ultimately improving long-term outcomes.
Such a pleasure of mine to watch your career grow. And you are now an assistant professor at Michigan State University. So that's been a really exciting transition for you. How does it feel to run your own lab now? And it's such a change from being, a PhD student.
Yeah, I think one of the interesting thing is, one, I do love having my own lab and and being able to think about whatever research I want to explore. I had the funds and the space to be able to explore those opportunities. I think what's probably different between being a PhD student to being a PI of a lab is that you don't have your mentor or your advisor saying, hey, you should probably submit this grant, or you should probably submit this paper. There's been a lot of growth as it relates to my own autonomous motivation and intrinsic motivation to get things out. That's just had to happen as I transitioned from this PhD student to a PI of a lab.
So tell us a little bit about what your work is and how you ended up along this path of research.
Yeah, so I like to say that my agenda has two different areas. I want to know what's happening in the brain from a psychological perspective, but I also want to know how we can train the brain from a psychological perspective to help patients who have traumatic knee injuries. So what my research, some techniques that we've used are neuroimaging, so looking at brain activity via functional MRI. We looked at neurocognitive functioning in this patient population to see how reaction time and sensory motor brain functioning, so visual cues, being able to respond to different stimuli, how that may be affected as a result of these psychological factors. And then on the other side of it is, can we find clinically friendly interventions that can be used to address these psychological factors in clinical practice? So from a physical therapy, athletic training, rehabilitation standpoint, what can we do while we're working with these patients to help to decrease things like fear and improve confidence throughout the rehabilitation setting with hopes of ultimately improving long-term outcomes? And one of the pieces that have really started to tie my research to is this idea of secondary injury prevention. So we see that patients who have history of ACL reconstruction specifically, who have increased levels of fear, when they go back to sport, they're 13 times more likely to have a secondary ACL injury. And we know that further damage to the joint could further predispose these patients to the development of knee OA. So my hope is to try and help to preserve this long-term joint health by addressing these psychological factors that have been associated with secondary injury risk.
I don't know if people are really aware of some of, when you talk about fear following injury, what that really means and how that affects athletes or people who are returning from injury.
Yeah, that's a great question. So when we think about fear after injury, fear itself is this emotional response to a stimuli that we think is potentially harmful to ourselves. So fear itself can be, and I always like to say this from a rehabilitation standpoint, it's ideally a protective mechanism. Mm-hmm. So we should have these fear responses. So when we face something that is potentially harmful for us, our body knows how to respond. But when we think about it from a very primitive standpoint, I always like to use this example of a lion. When we saw a lion in the wilderness, we had this fear and this emotional responses to trigger things like fight or flight responses. So our body knew how to respond to that situation. Now, fear when there isn't something to actually be fearful of. So let's say if we bring it back to knee injury, running, jumping, cutting, when they functionally are able to run, jump, or cut, can ultimately be pretty detrimental. It can prevent people from going back to sport, from engaging in lifelong levels of physical activity, which we know is important for just overall health and well-being. And then again, we're seeing this now tied to potentially having secondary injury in this population. So fear itself can be a good thing if the patient isn't necessarily ready, and it can be our body's way of telling us that, hey, we need to potentially adjust some of these functional limitations. But when the patient is functional and they have this fear, it could potentially lead to poor outcomes after this particular surgical procedure.
Right. And so a lot of your research has focused on interventions for that, right? So decreasing people's fear to help them get back to physical function, in a safe and sort of correct way. Do you want to talk about maybe an intervention or two that you've used?
Yeah, so in my research, and I will also say that I've done clinical training as a sports psychology consultant. So in my clinical work in that arena, and also in my research, I've used a term called graded exposure therapy. So essentially what exposure therapy is you're gradually exposing someone to what they're fearful of. So if we're thinking about it from like a fear of height standpoint, you gradually expose someone to a fear of heights. If they're afraid of spiders, gradually expose them to a fear of spiders. But in rehabilitation, we gradually expose them to the tasks that they're fearful of. If it's running, cutting, pivoting. What's really great about this tool from a rehabilitation standpoint is we follow the same progressive factors that we're already doing in rehabilitation. And instead of just using pain or soreness as our guide to progress someone through the stages of an exercise or a functional task, we use fear as our modifying factor. So it doesn't increase clinician burden to implement this intervention. All it is just asking an additional question and allowing that fear piece to help make a clinical decision about whether we should progress this patient from doing a double leg vertical hop to a double leg forward hop.
Well, and I loved what you said before about clinician friendly or clinical friendly tests and interventions, because I think that is something that's missing, right? Is we do all of these tests, we 3D biomechanics and all of these biomarkers, and we collect these specimens, and we're, looking at people in all of these different ways, but we're not able to do that in a clinic or on the field as athletic trainers easily. And so how do we, as researchers, give clinicians something they can implement that is actually implementable for them, right? You don't need any special equipment. You can do it in a reasonable amount of time. So I think that you bring up such an important point about, taking what we're finding, but then making it accessible to clinicians at all levels.
Yeah, and there's some research out there that suggests that rehabilitation specialists appreciate the impact of fear. They understand that confidence and fear are barriers. But what was interesting is that we know how to assess it, but our confidence level and rehabilitation specialist confidence level in intervening is much lower than it should be. Although it's within our domains and our practice guidelines to be able to intervene, we often see this disconnect between, I know this is what's happening from an assessment perspective, but I don't feel confident or know exactly how to intervene. So, taking it back to my research is identifying different ways that we can make this as clinically friendly as possible. So some of my other work is looking at virtual reality and using virtual reality techniques to potentially implement some of these psychological interventions to help make a lot of these psychological interventions clinician friendly, right, and plug and play devices so that a clinician who may not necessarily feel as confident can still help to intervene from a psychological perspective with their patient in a clinical setting.
So you mentioned virtual reality, so I have to ask about that intervention. So kind of walk us through that. What are patients seeing? How does that influence how they feel about their knee and their function?
Yeah, so specifically, we're using a device called the Limbix virtual reality system. And the Limbix system is a play off of at the actual brain system in the brain called your limbic system, which is your emotional regulation areas. So the VR system itself has a ton of different guided meditations that a patient can listen to while they're immersed in an environment of their choosing. So while the patient is undergoing, or let's say from a clinical standpoint, how we would apply this intervention there, let's say they finish their physical therapy, their rehabilitation, and they're on ice or they're on stem. Mm-hmm. You can put a headset on them, ask them what environment they want to be immersed into, whether they want to be at the beach today or the mountains today or the forest today. And then just hit a play button, and there's a guided 10-minute meditation that walks the patient through their mindfulness experience. So they're able to be immersed in the environment. And the VR piece of it is nice because it helps to enhance the mindfulness meditation by engaging auditory and visual senses.
Okay. Okay. So we see, a difference in people who are able to have sort of a comprehensive sensory experience as opposed to just one or the other. Is that correct?
Correct. So if we think about it from the function of our brain wants to interpret all this environmental stimuli. So if we can give the brain more environmental stimuli to lead to a relaxed state, so put them in an environment that they like, have them hear ocean sounds, have them hear birds chirp, whatever makes them feel relaxed, then we can help to really induce that relaxation and really lead to those changes in mindfulness, our ability to engage in mindfulness. Because psychological interventions work in a similar way as we're thinking about strength training. So if you go to the gym and you do your biceps curls, right? You go into your gym, you have your routine. Eventually you're going to see your biceps curls get big, your biceps going to get bigger. We're going to be able to curl more weight. It's the same thing from a neurological perspective. You're going to actually be able to see your ability to engage in those mindfulness techniques get easier, and you can challenge yourself more and do more weight as you continue to practice these skills. So this is why I use the term of training the brain, because just as you want to train like your muscles to get better and bigger, you also have to train your brain cognitively so you can implement these psychological techniques.
Got it. So it's more about creating these lasting neurological pathways, these connections, right? Because we know our brains are so neuroplastic. And that way, once you have this skill set, you can then apply that to movements or function that you may be fearful of. Is that sort of where, do I have that right?
Yeah. So once you're able to teach someone the skills in a nice, safe environment, the goal of it is to allow them to translate it when they're maybe in an unsafe environment, when they have to deal with a stressful athletic situation or a stressful functional task. Rather than ruminating about that task, they're now able to turn on their strength in their brain and learn how to stay present in the moment. Because mindfulness meditation techniques aren't about ignoring those feelings. It's about acknowledging them, staying present, and then being able to move forward instead of focusing on past events or ruminating about future events. I always like to tell this story about how I even started to appreciate the psychological factors. I was working clinically as an athletic trainer. I just got certified. I was by myself working a women's soccer camp, and it was my first time being by myself. And I go out on the field and this girl goes down and I do my Lockman's test. I do my drawer and it's pretty evident she's torn her ACL.
Yeah.
And I started to have this conversation with her, and then she just started listing off all of her accolades to me. She told me how she signed at XYZ University and how she held this national record and that national record. And I realized I had absolutely no idea how to help that girl. And for me, moving forward, I continue to see this similar cycle with my patients, specifically, I'd say my ACL patients too. And I began to appreciate the psychological side of things. So for me, my own personal endeavors, when I think about where do I want to go, I want to be able to help that girl that I couldn't help.
For OA, you need to age healthy. You need to age active. You need to continue to be active. Well, if you're afraid of being active because you don't want to hurt yourself, that's a barrier. And you're in the perfect position to help people get over that. So it's incredible. I think it's so cool.
Well, thank you. And hopefully we'll figure out some type of concrete information on how to help these patients in the future.
Absolutely. Well, it's always such a pleasure getting to chat with you. And, it's so nice getting to speak to my friend. We'll have to plan a visit soon. And this has been so wonderful. So thank you again, Shelby, for coming on and talking to us about this. I think it's such an important aspect of, patient care and rehabilitation. So, thank you so much. And we look forward to following your undoubtedly successful career.
Well, thank you. And thank you so much for having me.